Hi, today we will be talking about interferon beta drug, interferon alpha beta receptor gene in multiple sclerosis disease. Sclerosis means plaques or lesions in the central nervous system. Multiple sclerosis is defined as chronic, inflammatory, demyelinating disease of the central nervous system. Clinical symptoms include optic neuritis, motor impairment, sensory disturbances, tremor, to name a few. Here, in this image, you can see that the axon is labeled in green and myelin around it is in red. This schematic shows a normal axon and myelin. However, in multiple sclerosis, inflammatory cells attack myelin, causing demyelination. The distal end of the axon degenerates. The proximal end of the axon that is connected to the cell body forms ovoids, and these ovoids can be detected in MS tissue. There are many medications that are used to treat MS. Interferon beta is most widely used disease-modifying therapy for the treatment of MS. When on interferon beta therapy, patients have fewer and less severe relapses. There's delayed in disease progression. Patients also see slowing in the occurrence of physical disability. Side effects of interferon beta include depression, hallucinations, liver problems, serious allergic reactions, and skin reactions. Interferon beta is a cytokine that binds to heterodimeric receptor, interferon alpha beta receptor 1 and interferon alpha beta receptor 2. Nearly 50% of MS patients do not respond to interferon therapy. Here you can see that interferon beta binds to its receptor and then activates the JAK-STAT pathway that leads to stimulation of interferon responsive genes. There are different types of variations that are found in this receptor. Single nucleotide polymorphism and repeats have been detected. Population studies on Irish population and Spanish population have shown that some of these variants may be associated with interferon treatment response. There's no information about functional impact of these variations. Here I show you the polymorphic variants associated with response to interferon beta in multiple sclerosis. This slide shows all the important variants in red for interferon alpha receptor 1 and interferon alpha receptor 2. These sites show association with relapse-free status in patients treated with interferon beta. Candidate gene and GWAS studies are most commonly used strategies. There are lots of limiting factors in these studies. These studies require large clinical sample size, which is not always possible. Expression studies are also being done to find out candidate markers of interferon beta activity. However, there's no correlation studies done between genotype and gene expression changes. Multiple sclerosis is a complex disease, and definition of interferon beta responder is highly variable. Lack of rigorous, consistent clinical MRI criteria introduces high degrees of irregularities across various studies, making any direct comparison impossible. More than 100 genes are involved in interferon beta pathway, and all may be considered attractive candidates for pharmacogenetic responsive markers. Our knowledge about interferon response gene in MS is fragmentary. There is an increasing consensus on a polygenic mechanism of response. We still have a long way to go before biomarker discoveries can be translated into clinical practice to predict interferon beta responder status. A few references in this slide. Thank you.